be here, and thank you for um, signing up for this session. I'm going to talk about the application of pharmacogenomics in the treatment of ADHD. I have no financial relationships to disclose, and as we know, ADHD is a neurodevelopmental disorder and is categorized by inattention, hyperactivity, and impulsivity. It can affect approximately 5 to 7% of children and adults. Some of these numbers can vary a little bit, but they are around that type of same percentage. ADHD can also be heritable, and the pharmacotherapy is the cornerstone for the treatment, but as we know, the um, is highly variable. A little bit of background. So there are key brain networks involved. For example, the prefrontal cortex that is involved in like executive function, attention, and impulse control. The basal ganglia for motor activity and reward processing, and as well the cerebellum with timing, coordination, and cognitive regulation. And there's also neurotransmitter involved, which is where the pharmacotherapy takes place with dopamine and norepinephrine dysregulation. And these changes or dysregulations in these neurotransmitters can cause prefrontal cortex impairs such as working memory, behavior inhibition, and sustained attention. And there's also some neuroimaging findings like delay cortical maturation and reduced functional connectivity within attention networks. So, keeping up with the background, this catecholamine dysregulation, the prefrontal cortex needs those dopamine and neuroepinephrine signaling, and having that hypoactivation on this pathway is associated with how ADHD is being studied. And there's also a genetic architecture, like ADHD is highly heritable, and we have the dopamine transports involved, catecholamine metabolism, and that genetic variation can influence both the disease risk and medications response and tolerability. The diagnosis is mostly a combination of like clinical and also some assessment like the DSM-5. For example, persistent pattern of inattention, hyperactivity or impulsivity that at least presents for more than 6 months, and maladaptive and inconsistent with the developmental level. As well, there are some like DSM-5 requirements, for example, severe symptom presence before age 12, and symptoms occurring in two or more settings like school, work, or home, um, evidence of like functional impairment, and symptoms not explained by any other disorder. So putting those two together, then clinicians made the diagnosis. We do have pharmacotherapy, as we all know. Stimulants are mostly first line in children, adolescents, and adults. We have methylphenidate-based stimulants that inhibits dopamine and norepinephrine reuptake, primarily affecting the prefrontal cortex. And evidence might prefer that when we have like younger patients, appetite suppression or insomnia with amphetamines, if we have those kind of like adverse events or if patients report that. And we also have amphetamine base that increases dopamine and norepinephrine release. They might have greater potency and longer duration, but they can have as well side effects like appetite suppression, anxiety, and blood pressure elevation. We also have other second line pharmacotherapy or medications where stimulants are not appropriate. For example, we have atomoxetine. It's a selective norepinephrine reuptake inhibitor, and it can be preferred when stimulants are not appropriate. For example, if patients reports anxiety or if they have a background for substance use disorder. We also have guanfacine or clonidine, and they are an alpha-adrenergic agonist. They might be helpful for hyperactivity, impulsiveness, aggression, and sleep disturbance. And we also have other medications like viloxazine, FDA approved for treatment in ADHD and pediatric patients aged 6 to 17. The role, at least in the guidelines, had yet to be determined. And there's also other medications like antidepressants that can be used or considered if they have co-occurring disorders. For example, bupropion, off-label for certain patients if they don't tolerate stimulants or atomoxetine and alpha-adrenergic agonist. And guidelines or some or guidelines probably consider tricyclic antidepressant, although we know that is not considered or used first line or anymore. So regarding the challenges in ADHD pharmacotherapy, we do have our stimulants and our non-stimulants, but we all know that the response rates can vary between children and adults, and there is also problems with the trial and error of prescribing. Patients can report side effects and poor adherence due to those side effects. So that's why pharmacogenomics can take place in trying to answer and put evidence together to better direct those treatments and avoid the trial and error in prescribing, having more precision. So we also, regarding methylphenidate and pharmacogenomics, methylphenidate is primarily metabolized in the liver by carboxylesterase 1 or CES1, and up to 80% of methylphenidate or MPH is hydrolyzed to ritalinic acid. So CYP enzymes play minimal role, unlike other medications like atomoxetine, which has probably higher evidence of being affected by CYP enzymes. But there's been a few studies of this CES1 regarding methylphenidate, and there's been a couple of variants that have been mostly studied, like this one here, the 716477871, and it describes a substitution of glycine to glutamic acid. And this can show a slower MPH metabolism, resulting in higher systemic exposure. Trying to find evidence for methylphenidate when we're working patients, there's Clean PGx, which is like a comprehensive like clinical pharmacogenomic resource, and they categorize this methylphenidate evidence as level 3, and they only have this in their website, like patients with ADHD and that have this variant identified may require an increased dose of methylphenidate compared to patients that have the CT genotype. As well, the CT patients that have CT genotype may require a decreased dose of methylphenidates compared to patients that have the CC genotype. And regarding the TT genotype, there's no evidence regarding association of these and with those requirements. A few studies that I look more into regarding the CES1. There is a study design in at pharmacogenomic testing among 122 ADHD children treated with MPH or methylphenidate. And this categorical analysis and the dimensional analysis of ADHD score reduction did not show a significant main genotype effects. They did saw, however, an association of the glue variant in 5 patients that require lower doses of methylphenidate for symptom reduction. But as well, the sample size, it was a small group size, and only 7 patients carry this allele. Difference in daily doses was also relatively small based on those 5 patients responding to MPH. And there is also another study called the association between CES1 variant and dosing and adverse effects of children taking MPH or methylphenidate. And this retrospective cohort study included patients of 6 to 17 years of age treated with MPH. The cohort was 99 patients, and they, however, observed another variation, RS11411997 and that was associated with a weight-based dosing in 2 individuals. But as the evidence regarding this methylphenidate medication and CES1 is there's not that much evidence. There's still not CPIC guidelines yet published on this study or any other recommendations. And also, there is not a lot of patients that have been studied with any of these variants as well. There's the studies published are only for like small subjects. So that's one of the main, that's where the evidence is at right now regarding methylphenidate. Atomoxetine is most studied. It's a selective norepinephrine reuptake inhibitor and is primarily metabolized by CYP2D6. Atomoxetine has current labeling dosing, but with CYP2D6 patients that are identified as poor metabolizer, they start therapy at the usual dose and then increase to 1.2 milligrams per kilograms per day if they don't tolerate symptoms or fail to improve after 4 weeks. But there is key finding or evidence, strong evidence for patients that are poor metabolizer. They can exhibit 10-fold higher AUC levels and at least 5% fold higher Cmax versus patients that are normal metabolizers. And as well with CYP2D6, we need to take into consideration the phenoconversion when there is other medications that can increase this phenoconvention risk, like fluoxetine or paroxetine, that patients that can be normal metabolizer will be converted into poor metabolizers. We do have CPIC guidelines for these patients, at least patients that are poor metabolizers, or the CPIC guidelines recommend or states that these patients can have higher, they can respond better to atomoxetine, even though they can have a high risk for side effects as well. So they do recommend for patients that have poor metabolizer, the guidelines say that they have significantly decreased metabolism of atomoxetine, and that can result in higher concentration, but these will also help them in the treatment for or response. There are evidence or studies that also reflect this. So we do have this therapeutic drug monitoring of atomoxetine in children and adolescents with ADHD, and they also find, or they also having the evidence that patients that are poor metabolizers have that 9 to 10% higher concentrations of atomoxetine. An intermediate metabolizer can have like around 2% higher exposure as well. And we also have this other study called effect of CYP2D6 and CYP2C19 genotypes on atomoxetine. And they also find that patients that are CYP2D6 poor metabolizer or IM can have around that same exposure of atomoxetine, like around 1.1 for IMs and then around 9.6 folds for PMs. Interesting though, they also find that patients that have CYP2C19 STAR2 allele carriers, they also had a 1% fold higher atomoxetine exposure, regardless of the CYP2D6 genotype. So these key findings of CYP2D6 continue confirming the impact of atomoxetine exposure. And as I mentioned before, the evidence for this one is a little bit higher, and we do have as well CP guideline recommendations the on how the patients can probably the side effects that the patient can experience, but as well the response to atomoxetine for those PMs. And then we also have vilaxosine. The mechanism is unclear, however, they are thought to be to inhibit the reuptake of norepinephrine, primary via CYP2D6 hydrolyzation as well. There are few studies of vilaxosine and CYP2D6. I did find this impact of paroxetine as strong CYP2D6 inhibitor in vilaxosine extended release, and they study vilaxosine 700 milligrams alone, then paroxetine 20 milligrams for 10 days, and then they be vilaxosine plus paroxetine 72 hours post dose. And this was studied in 22 adults. And they define that vilaxosine exposure increased modestly when co-administered with paroxetine, which is a CYP2D6 inhibitor. So the evidence so far stated that paroxetine caused less than 35% increase in vilaxosine exposure. However, it's unlikely to be clinically significant. Um, and they didn't find no dose adjustment generally needed, but they did advise monitoring for vilaxosine. And we also have a vilaxosine package warning regarding CYP2D6 metabolism. So patients that have poor metabolizers, they did advise for that probably high concentration of vilaxosine in those patients. And we also have amphetamines. The evidence regarding amphetamines as well, there is not that much evidence, but we do have package labeling again for this one regarding CYP2D6 involvement with amphetamines and advising the dose adjustments as well. And I did find this study called the effect of CYP2D6 genetic variation on patients that reported symptom improvement and side effects among children and adolescents treated with amphetamines. And they find that patients that were poor metabolizer, they had a 3% fold higher of reporting improvement compared to intermediate metabolizers. So they suggest higher graded efficacy in this study, and this was published on January 2024, which is kind of um, contradictory to what the package insert is stating right now, but it's a pretty recent study. And then when we are talking about ADHD treatment, like I mentioned before, we need to also take into consideration the phenoconversion aspect that patients that are currently also using fluoxetine, paroxetine, and any of these other drugs can have that change in the um, from normal metabolizers to poor metabolizers, and it's a concept that we have to keep in mind. So these are my references.